Good evening, everyone. Before we start, just confirm if the audio video is good. Thank you, Dr. Isra. Thank you for confirming. Can I have more confirmations? Good evening, everyone. So, today's topic is very important. Today, we will be discussing preeclampsia, APH. These two topics, definitely we are going to get two questions in our exam from this topic. More than two are expected, but yes, one question on preeclampsia and one question on APH, right? It is equally important for NEET PG, equally important for FMG, equally important for the final year exams, and equally important for the INI SIT. Okay, so these all are very important topics. Preeclampsia, APH, these topics are very important. Okay, so if you all are ready, please give a thumbs up if you're good to go. Okay, so starting with preeclampsia, first of all, there will be definitions. Question do come on definitions. Okay, so what is acute on chronic hypertension? Thank you, Dr. Himani. What is acute on chronic hypertension? If already the chronic hypertension was there before conceiving, the patient had hypertension, and plus now in the pregnancy the patient is having preeclampsia. So what is acute on chronic hypertension? Questions are asked. Always remember, in FMG we get basic question. What is the definition of acute on chronic hypertension? The patient was having chronic hypertension, but now the patient has preeclampsia features also. Let us study what is gestational hypertension. If the BP increases more than 140/90, please write down in the chat box what is the criteria to say gestational hypertension. If the BP increases more than 140/90 after 20 weeks, why it is after 20 weeks? Can anyone tell me why the BP increased after 20 weeks is considered the preeclampsia? Why? Because normally at 20 weeks the extravillous trophoblast cells, there are beta two types of trophoblast cells, villus and extravillus. Extravillus trophoblast, they do the other jobs. The villus trophoblast, they makes the villi. Are you getting my point? So the extravillus trophoblast, what they do? They remove the tunica media of the spiral artery. This is what happens normally. Okay, this is what happens normally. What happens normally? That the tunica media of the spiral arterioles. What is spiral arterioles? See, the uterine artery, this order was once asked in exam. This is the uterine artery. Okay, this in the periphery. It gives a branch arcuate artery. Okay, these are the arcuate artery. What branch the uterine artery gives? Like a arc. Okay, like a arc. On the lateral side of these dotted structures are uterine artery. They give a branch arcuate artery. Now this arcuate artery, which is outside the uterus, they gives a branch radially. Okay, so I'm actually it's 2D. I still would like to make it like this radially, which goes inside the uterus. Okay, which goes inside the uterus. and the arcuate artery gives the branch radial artery. The radial artery further divided into basilar artery and spiral artery. So in total you can say uterine artery gives a branch arcuate artery gives a branch radial artery, and radial artery then gives the branch basilar and spiral. So how you are going to remember this? Okay, uterine artery, U R A R U Arbs. You Arabs. Okay, write down the mnemonic in the chat box. You Arabs. Okay, uterine artery gives a branch arcuate artery, just like the arc it circles the uterus. Then in the periphery, then from that arc rises the radial artery which goes inside radially, inside the uterus radially, and then that radial artery bifurcates into basilar and the spiral arteries. Okay, now this spiral artery tunica media is normally removed by the extravillous trophoblast, because villous trophoblast they makes the villi. So extravillous trophoblast do the extra work. Okay, so they remove the tunica media. But if there is no removal of this or poor removal of this tunica media, then there will be vasospasm. See, it is written here in the corner. Then there will be vasospasm. Okay, then that vasospasm will lead to preeclampsia. Okay, so poor invasion of the extravillous trophoblast and less removal of the tunica media leads to vasospasm. This vasospasm is present also in the fetus vessels, also in the maternal vessels, which increases the BP. Okay, so this is the main problem. So what is the gestational hypertension? If BP increases more than 140/90 after 20 weeks. So if there will be poor invasion, and then there will be hypertension. Now, what is preeclampsia toxemia or preeclampsia? If along with high BP there is proteinuria, proteins is also coming out from the urine, it means vasospasm is of severe variety, or there is end organ damage. Okay, just remember here, what is severe preeclampsia? If BP high is more than 160/110, then it comes as severe preeclampsia. Okay, all these definitions are very important. What is severe preeclampsia? If increase in BP is more than 160/110, or the liver enzymes are increased 2 times, or platelets are less than 1 lakh. These are the criteria of help. Okay, these are the criteria of help. Or if there is cerebral hypoxia symptoms, just like headache, visual disturbances, dizziness. Okay, so if there is BP is very high, any one of them, or health symptoms are there, liver enzymes increase 2 times, platelets less than 1 lakh. Okay, what is chronic hypertension? If already the BP was high before 20 weeks, pre-conceiving, before conceiving, if the BP is high, then it will come increase BP before 20 weeks. And what is eclampsia? Preeclampsia plus convulsions. Is it okay? Okay. Now let us discuss the management. So if the proteinuria is present, then it is preeclampsia. If BP is more than 160/110, then it is severe preeclampsia. And if it is before 20 weeks, it is chronic hypertension. If convulsions come, then it is eclampsia. What is the treatment of mild preeclampsia? If the BP is less than 160/110, what is the management? We will terminate this. No mag sulfate is to given, No antihypertensive is to be given. We will terminate this pregnancy at 37 weeks. Just remember this. Okay, termination at 37 weeks. Okay, if it is a severe preeclampsia, that is BP has gone more than 160 by 110. Okay, this is 110. If BP is more than beta 160 and by 110, now there are a fixed management. Okay, this question is much expected. This line is much expected. The treatment of severe preeclampsia. Now we have to give antihypertension. We have to give max sulfate so that the severe preeclampsia does not affect the brain. Yes, Dr. Isra. After the gestational hypertension comes the stage preeclampsia. Okay. Yes, you're right. So antihypertension, along with antihypertension, we have to give max sulfate so that eclampsia does not happen. Okay, and we have to terminate it at 34 weeks. This 34 is very important. Okay, this 34 is very important. Okay, now what are the signs of impending eclampsia? See, you all know that in what are the sign of impending eclampsia? What are the sign of impending eclampsia? Okay, the signs of impending eclampsia means that you should know which patient will go into eclampsia. You have to keep that patient near ventilator, because an eclamptic patient can aspirate and expire, right? As if during eclampsia, during convulsion, if that patient aspiration occurs, then that patient will die, right? Cerebral hypoxia symptoms are there. What are cerebral hypoxia symptoms? What are signs of impending eclampsia? If the patient gives you symptoms of cerebral hypoxia, what are symptoms of cerebral hypoxia? Yes, headache, visual disturbances. Okay, headache and visual disturbances. And what are the signs of liver involvement? If liver is involved, then again there are chances beta ki cerebral hypoxia will occur, because liver is involved at last stage. Epigastric pain, nausea, vomiting. So these are the signs of impending eclampsia. Quite sure question. Right? What are the signs of impending eclampsia in a patient of preeclampsia? They quite often ask you. So you will group the signs into two categories. Cerebral hypoxia. If cerebral hypoxia is there, patient will say you headache and visual disturbances. If the liver is involved, then the patient will give you two symptoms: epigastric pain, nausea, vomiting. So these are the symptoms. If the patient complains you of this symptom, then you are going to keep the patient near the ventilator, because this is a patient of impending eclampsia. What is the management of impending eclampsia? Patient is soon will be throwing fits. What is the management? Please tell me. Management is not that of preeclampsia. Management is of different. Now here you have to give max sulfate so that this patient does not throw fit. You have to give antihypertensive so that cerebral hypoxia decreases. But now the termination is not at 34 weeks. Now it becomes a completely different scenario. The termination will be immediate. Once the patient has stabilized, the termination will be immediate. Okay, all the questions in preeclampsia are asked on management. Okay, so here we will be having a discussion on management mainly. Right? Our target is to clear the exam. So if in the exam they are asking management, we will discuss management only. Okay, so what is the treatment of impending eclampsia? Impending eclampsia treatment is max sulfate, antihypertension, and terminate immediately after stabilizing the BP. Okay, no 34 weeks criteria is there, right? Now let us see what is the preferred mode of delivery. The preferred mode of delivery is normal vaginal delivery. We will do the cesarean only for the obstetric indications. The preferred mode of, if we are doing cesarean, then what is the no, Dr. Isra, anuria is not a sign. It has been removed 1 year back. First, we used to consider anuria as a sign of impending eclampsia, but now it is no more. Okay. So, what is the preferred mode of delivery? The preferred mode of the delivery in preeclampsia is, yes, normal vaginal delivery. Cesarean is only reserved for obstetric indications. Okay. What is the preferred mode of anesthesia? Question in the NEET PG. Please, in FMG NEET PG questions, repeat a lot. What is the preferred anesthesia if cesarean occurs in preeclampsia? For example, if the patient has fetal distress, we will do, it is an obstetric indication. What is the preferred anesthesia? The preferred anesthesia is epidural. Okay, preferred anesthesia is epidural. Okay, the eclampsia. What is eclampsia? Patient is throwing convulsions. Patient has gone into cerebral hypoxia. Now the first step, questions are asked quite frequently on first step and next step. The first step will be to maintain the airway. Why? Why the first step? Because patient is throwing fits. If patient will aspirate, then patient will expire. Okay. Yes, Dr. Isra, cardiac patient. In cardiac patient also we give epidural anesthesia. You are right. So, in the eclampsia, the first step, if the patient is throwing fits, these days questions are asked on first step and next step. First step will be to maintain airway because patient is throwing fit. If patient will aspirate, patient will expire. फिर हम किसकी डिलीवरी करेंगे, हम किसको मैक्स सल्फेट देंगे, to whom we will give max sulfate, to whom we will give terminate. So first is resuscitation, so maintain airway. Okay, next is you will give max sulfate and antihypertensive to treat that cerebral hypoxia, and now immediate termination, no waiting till 34 weeks, no need to wait for betamethasone, even if it is 30 weeks. Whatever is the period of gestation, if patient has thrown convulsions, you have to immediately terminate it. Okay, immediately terminate it. Right? So, you will remember that in mild preeclampsia, we wait till 37 weeks. In severe preeclampsia, we wait till 34 weeks. And in impending eclampsia, we wait for stabilization of the condition, but in eclampsia, even in convulsions, we start termination. Okay? Okay? So, no conservative management in eclampsia. Please note this thing. Quite often, students tell me, ki, ma'am, we do it at 34 weeks. Not at 34 weeks. Once the patient has thrown fits, you are going to terminate the patient. Okay, now this is quite expected question in your exam, because in INS set November question has come on severe preeclampsia. Now in your exam the question will be nearby. So nearby is eclampsia or impending preeclampsia. Eclampsia or impending eclampsia. Okay, in impending eclampsia you have to stabilize the BP and then terminate. In eclampsia, you have to not stabilize the patient, you have to start termination, because cerebral hypoxia is something very emergency. Okay, now let us study HELP. What is HELP? HELP is a condition in preeclampsia where the hemolysis is occurring. So they don't directly tell you hemolysis is occurring. How they tell you? They tell you that LDH is increased. LDH, what are the indication they give for hemolysis? LDH is increased, serum bilirubin is increased, right? Right? And helmet cells or schistocytes or haptoglobin is decreased. These all are indirect indications of hemolysis. Okay, this is very straightforward thing, that if they say LDH is increased, bilirubin is increased, is the helmet cells are present, schistocytes are present, haptoglobin is low, all this indicates that it is a case of hemolysis. Along with hemolysis, if liver enzyme are raised, okay, how much the liver enzyme are raised? H stand for hemolysis, EL stand for elevated liver enzyme. 2 times. Write down in the chat box. 2 times, beta. 2 times. 2 times liver enzyme raised in the range of 60 to 70. Okay? In the range of 60 to 70. The platelets, they are less than 1 lakh. Okay? Simply these values are given and we have to diagnose that this is help. That is asked in our exam. No great things. Simple. So only they twist the hemolysis criteria. They give LDH is increased, serum bilirubin is increased, is haptoglobin is low, helmet cells. Okay? Okay? And you have to remember one thing. Yes, Dr. Isra, liver enzymes, they get double. Okay? You have to just remember one more thing, that in 20% of cases, the BP is normal. This was asked in NEET PG, that in HELP BP is normal. What is? They have given hemolysis, LDH increased, elevated liver enzyme, platelet was low, less than 1 lakh, but they have written that BP was 110 and 70. So BP is normal in HELP in 20% of cases. In 20% of cases, BP is normal. It is not essential that BP is high. And that's why you get confused. Please mark this line in red color. BP is normal in HELP in 20% of the cases. Next question is how you will differentiate this from cholestasis, right? Dr. Rahul, the sessions are totally oriented toward FMG. The sessions are totally oriented toward FMG. You are always welcomed. Okay? Okay, what is the differential diagnosis of cholestasis? The differential diagnosis of is cholestasis. What is the differential diagnosis of HELP? Cholestasis. What is cholestasis? If they have given you hemolysis, elevated liver enzymes, low platelet count, then they in the options they will be written cholestasis. What is cholestasis? Cholestasis is that patient has increased bile acids. Okay, it is written here in the corner. Patient has increased bile acids. Due to increased bile acids, there are liver enzyme increases and there is jaundice. Okay, there the liver enzymes are increased and there is jaundice. Okay, are you getting how you will differentiate that this is HELP and this is cholestasis? Because liver enzyme and jaundice are present in cholestasis also. In cholestasis, there will be no decrease in the platelet. Write down, there is no decrease in the platelet. Okay, there is no decrease in the platelet and there is no increase in the BP. Okay, are you getting? This is how you, and most important thing, in cholestasis, patient will give you the history of pruritus, itching all over the body, right? The negative things which will not be present is that there will be no decrease in the platelets and there will be no increase in the BP in cholestasis. And significant thing that in the pruritus, in the cholestasis, pruritus will absent. Can you write down in the chat box what is the drug of choice for cholestasis of pregnancy? Please write down what is the drug of choice for cholestasis of pregnancy. Write down in the chat box. Ursodeoxycholic acid. Yes, very good, Dr. Isra. The drug of choice for cholestasis of pregnancy is, yes, Dr. Prashant, you're right. Platelets are normal and there is history of pruritus. Okay. So, tell me that what is the drug of choice is in cholestasis. No, Dr. Isra, it is not cholestyramine. The drug of choice is ursodeoxycholic acid or Udiliv. Okay, ursodeoxycholic acid or Udiliv. Let me write here. Ursodeoxycholic acid, okay, or Udiliv. Okay. Now, in what happens in cholestasis of pregnancy, there are only fetal complications. Mother has only pruritus and there are only fetal complications like meconium stain, liquor, IUGR, IUD. So we terminate this pregnancy at 37 to 38 weeks. Okay. What is the management of HELP? What is the management of HELP? Yes. The management of HELP is antihypertension and mag sulfate and terminate after betamethasone if it is a very premature, because HELP is not emergency like cerebral hypoxia. So we can wait till 48 hours of betamethasone. Okay. We can wait till 48 hours of betamethasone. So in the HELP we can wait till 48 hours. Okay. Now I have completed all the managements. Can you tell me what is the management of, what is the, write down in the chat box. Now I will ask you 4 questions and out of these 4 beta, 1 is going to come in your exam. Okay. It's a sure question. What is the management of severe preeclampsia? Write down in the chat box. What is the management of severe preeclampsia? Write down in the chat box. Now I will ask you 4 questions. 1 question is final in the exam. What is the management of severe preeclampsia? What is the management of impending eclampsia? Please write down, students. You will get your number reserved in your exam if you write down. I know we all hesitate, but if you will write down, then your number are reserved. Management of severe preeclampsia, management of impending eclampsia, management of eclampsia. Yes, Dr. Isra, management of severe preeclampsia is mag sulfate. Others, please you also write down management of eclampsia and management of HELP. Please write down what is the management of severe preeclampsia. The management of severe preeclampsia is antihypertension plus mag sulfate plus termination at 34. Management of impending eclampsia is mag sulfate plus antihypertension, termination not at 34, termination after stabilization. Termination after stabilization. In the management of eclampsia, what is there? Maintain airway. You have to Patient is throwing fit in eclampsia. Maintain airway plus mag sulfate plus antihypertension plus immediate termination. Immediate termination. In the help, you have to give antihypertension plus mag sulfate and terminate after betamethasone. Terminate after betamethasone. So one can give betamethasone in help. Help is not that emergency. So I hope now you get the clear cut idea that in eclampsia the termination is immediate. And in impending eclampsia the termination is after stabilization, and in severe preeclampsia the termination is at 34 weeks. That is what will be asked in your exam. Okay, that is what will be asked in your exam. Next is acute fatty liver of pregnancy. When they will ask you to make the diagnosis about the health, the other thing which they will ask you is acute fatty liver of pregnancy in the options. One option they will put cholestasis. The other option which you will put in the options will be acute fatty liver of pregnancy. Please listen here. In the acute fatty liver of the pregnancy, see, these are the signs by which you will differentiate. There is hypoglycemia, there is coagulation failure, there is encephalopathy, and there is hepatorenal syndrome. These are the 4 features by which you will differentiate. Okay, that how you will differentiate that this is a case of acute fatty liver of pregnancy. There will be hypoglycemia, there will be coagulation failure, there will be encephalopathy, and there will be hepatorenal syndrome. Okay, so you will differentiate. If there is pruritus and if there is no increase in the BP and no decrease in platelet, then it is cholestasis. If there is hypoglycemia, coagulation failure, encephalopathy or hepatorenal syndrome, then the diagnosis is acute fatty liver of pregnancy. Okay, so now we have now we know how to manage the acute fetal liver of pregnancy, also how to diagnose acute fatty liver of pregnancy. Let us see what are antihypertensive of choice. Right, the antihypertensives of choice are in any condition, whether they give you severe preeclampsia, whether they give you emergency preeclampsia, whether chronic hypertension, impending eclampsia or eclampsia, or they give you any condition, right, the drug of choice will always be labetalol. More questions are asked, which drugs are contraindicated. The mnemonic for it is double A, B, there is no C, stands for contraindicated, and 2D. Okay, what is A? AC inhibitor and ARB, angiotensin receptor blockers. Okay, angiotensin receptor blockers. B stands for beta blocker, D stands for diuretics, and another D is for diazoxide. Questions are more asked on this. Please focus. Contraindicated. What are contraindicated? Because all of these are teratogenic, so they are contraindicated. Okay, now the questions on mag sulfate. Please listen carefully. The questions on mag sulfate. Okay, mag sulfate has a very narrow therapeutic range. Mag sulfate has a very narrow therapeutic range. What is its range? It is just a 4 table, 4 to 8. What is the Narrow therapeutic range, it is 4 to 8. Okay, it is 4 to 8. Okay, and knee reflexes are gone in because मैक सल्फेट की टॉक्सिसिटी बहुत जल्दी होती है. Max, what is the therapeutic range? 4 to 8. Most of you are doing wrong in quiz. Okay, max sulfate is only therapeutic at this range only, students. Max sulfate is only therapeutic at this range. I'm surely telling you this slide will cost you one question. Please focus. Right? Max sulfate, where does max sulfate acts on brain? Tell me. At what receptor max sulfate act? Most of you mark in quiz calcium receptors. It is not calcium receptors. It is NMDA receptors. See, it is written on top. It is NMDA receptors on brain it acts and it is neuroprotective. Okay. The therapeutic range of magnesium is very narrow. Okay. The knee reflexes goes on. It is directly 4 ka table. 8 to 12. Okay. If you have to mark 1, please mark 10. The beach wala range between 8 to 12 is 10. Okay. And knee reflexes go. This is the first sign of max sulfate toxicity. So always before giving the maintenance dose, you have to check the knee reflexes. Okay. You have to check the knee reflexes. If knee reflexes has gone, it means magnesium is in the range of 8 to 12 and soon the patient will have toxicity, magnesium toxicity. Respiratory depression. Respiratory depression occurs on 12 to 16. Okay, at 16 respiratory arrest occurs. After 16 there is cardiac arrest, cardiac rate depression. Okay, now because urine output is also checked, because the max sulfate is mainly excreted through kidney. Because max sulfate is mainly excreted through kidney, so urine output is also checked. 3 things are checked while we are giving max sulfate. 3 things are checked to see whether toxicity of max sulfate is occurring or not. Number 1 is knee reflex, number 2 is respiratory rate, and number 3 is urine output. Okay, these 3 things are checked. Okay, now what is the antidote? What if knee reflexes goes? Respiratory, you were giving the patient max sulfate, दे रहे थे आप किसी patient को. Okay, patient was a case of impending eclampsia. You gave the patient max sulfate. Right? Knee reflexes goes off. What is your management? Now you know that patient is going in max sulfate toxicity. What is your management? The management is calcium gluconate. What is the dose? 10 ml of 10% calcium gluconate IV. बड़ा वाला इंजेक्शन जो 10 ml का आता है, the big injection. Okay, so it is an antidote of magnesium sulfate. Please remember. Now they know that you are reading max sulfate very well. They ask question from here also. This max sulfate has no effect on BP. Our staff is always giving one drug. ठीक है, either they are giving max sulfate or they are giving antihypertensive, and we as consultants are very in trouble with this staff behavior. So always the examiner give you the question, max sulfate has max sulfate lowers the BP. No, max sulfate has no effect on the BP. Max sulfate is just a neuroprotective. It does not let the fits to come. This is a pet question of examiner in NEET PG, in FMG, in every exam. Because of our staff gives only gives either antihypertensive or max sulfate. So, the max sulfate has no effect on BP. Max sulfate can act as tocolytic agent. Okay, Mac sulfate can act as tocolytic agent. Mac sulfate is neuroprotective in less than, if given less than 32 weeks. Okay, what is the regime which we give? What is the regime which we give? Pre-charred regime. Okay, in this 10 gram is given IM and 4 gram is given IV. Loading dose of pre-charred regime is 14. 10 gram IM and 4 gram IV. Thereafter maintenance doses is given every 4 hourly 5 gram. Next expected question is, up till what the maintenance dose is given? Maintenance dose is given 24 hours after the delivery or 24 hours after the last seizure. This is the next expected question in your exam. Up till what the maintenance dose of magnesium sulfate is given? Magnesium sulfate maintenance dose is given 24 hours after the delivery or 24 hours after last seizure, whichever is later. Okay, because now they know that you are knowing this max sulfate की लोडिंग डोज आप सबको पता है. अब नेक्स्ट क्वेश्चन वो मेंटेनेंस डोज पे बनाएंगे. ठीक है, अब क्योंकि आपको यू ऑल आर नोइंग द फैक्ट दैट max sulfate is has no effect on BP, so they are asking what is the effect of max sulfate on fetus. Next question which they can ask is, what is the effect of max sulfate on fetus? It has the same effect. जैसे कि in the mother it is the knee reflexes goes. In the similar way, if the max sulfate is given to the mother, it also affects the fetus and it causes hypotonia and respiratory depression in the fetus. No new things. Fetus is also a human body. Same effects are occurring in the fetus also. Okay, what is the effect of the magnesium sulfate pre-charred regime on the fetus? Okay, in the last exam they have given it stimulates the respiratory system of the fetus. No, it does not stimulate the respiratory system of the fetus. It causes respiratory depression. It causes hypotonia. Okay, to whichever mother we have given max sulfate, the baby lives in the nursery for 2 to 3 days. Right? Is it okay? Now all the preeclampsia is finished. Okay, from all this discussion, one question is definitely going to come. I am writing here on the slide what all question will come. You should know. You should know the management of mild preeclampsia. Right? You should know the management of severe preeclampsia. You should know the management of impending eclampsia. You should know the management of eclampsia. Okay? You should know the management of HELP. Then the other question which is expected is, no dear Isra, it is not a sign of impending proteinuria, is not a sign of impending eclampsia. Okay, it is proteinuria means preeclampsia. That's it. Right? You should know the max sulfate therapeutic range, in the toxicity of max sulfate, the therapeutic range, the toxicity of max sulfate, the IM maintenance dose of max sulfate कब तक देनी है, the effect maintenance dose of max sulfate and effect of max sulfate on fetus and effect of mac sulfate on BP. From this, I tell you, on 20th January when you will come out, the question will be from these 10 question, one question is sure going to come. Okay, what is the management of mild preeclampsia? Terminate at 37 weeks. What is the management of severe preeclampsia? Mac sulfate, antihypertensive, and terminate at 34 weeks. What is the management of impending eclampsia? Mac sulfate, antihypertensive, and terminate at once the BP is stable. What is the management of eclampsia? Airway management. Maintain the airway. Then give mac sulfate. Then give antihypertensive. Then terminate immediately. Don't wait. What is the management of HELP? You can wait for betamethasone. If the pregnancy is premature, you can wait for betamethasone. HELP is not an emergency. What is the therapeutic range of mac sulfate? 4 to 8 milliequivalent per liter. What is the toxicity? Toxicity started after 8. 8 to 12 is reflexes goes. Deep tendon reflexes goes. Knee reflexes goes at 10. Okay. What is the maintenance dose of magnesium sulfate? 5 gram IM after till 24 hours after the delivery or 24 hours after the seizure, whichever is later. What is the effect of magnesium sulfate on fetus? Fetus goes into hypotonia and respiratory distress, respiratory failure. Mac sulfate has no effect on BP. Mac sulfate has no effect on BP. Let's now do APH, antepartum hemorrhage. Okay. What is the definition of antepartum hemorrhage? Any one of you, please write down in the chat box. Bleeding after, genital bleeding after 28 weeks. Okay. Genital bleeding after 28 weeks. If the bleeding is occurring after 28 weeks, it will definitely harm the fetus and mother. The two main reason of APH is, you all know this, abruptio and placenta previa. Okay, which is more common? Abruptio or placenta previa? Both of them risk factors are asked. On this slide there is risk factor. Please listen carefully. What is abruptio? Please listen carefully. What is abruptio? What happens in abruptio? The spiral arteries which are supplying the placenta, they tear. Okay, the spiral arteries which were supplying the placenta, they tear. Okay, they get tear down. Okay, so now the spiral artery problems will lead to abruptio. Okay, they are going to ask you these things. Okay, which all factors lead to abruptio? What are the risk factors? On abruptio, no one-liners are expected. Clinical questions are expected. And in clinical questions, they give you the risk factors. So, what happens in abruptio? In abruptio, there is premature separation of the placenta. Why there is premature separation of the placenta? You all are going to write down here. Because the spiral arteries, they tear. Okay? Spiral arteries, they tear. When the spiral arteries, they tear, they lead to premature separation of factors. And what are the factors which tear the spiral arteries? Preeclampsia. We studied that there is vasospasm. Right? We studied that there is vasospasm in preeclampsia. So that vasospasm will tear the spiral artery. Trauma in elderly and multiparous lady. Thrombophilia disorders. They will also tear the spiral artery if there is thrombophilia is present. Anything which over distend the uterus, like polyhydramnios. Okay. Then previous history of abruption is the most important. In 15% of the cases, the most important factor is previous history. Okay, got it? In the last smoking. What are the factors which lead to placenta previa? Very important. What are the factors which lead to placenta previa? If there is any scar on the uterus, even if there is a history of extensive curettage, okay, then the placenta grows with the growth of the uterus. In the initial stages, placenta is lying down, but with the growth of the uterus, placenta goes up. But if there is in between there is scar, then how the placenta will go up? Placenta will not go up. Okay, placenta will not go up. Okay, there will be the scar will not let the placenta to go. The placenta will now remain down. Okay, in the twins there are two placenta, so uterus is very small in size. Again, elderly, multiparous, and smoking, and previous history of placenta previa, and in the last, in the case of the Mullerian anomalies. Okay, in the case of Mullerian anomalies, as you are seeing, multiple factors are responsible for or abruptio, preeclampsia, trauma, thrombophilia, polyhydramnios, twins, all these factors. So more are the risk factors, more is the disease is prevalent. So which diseases is more? Abruptio is more common or placenta previa? Abruptio is more common, right? Abruptio is more common, right? So now let us study the abruptio. Now in form abruptio, we are expecting the clinical questions. Okay, so just remember, when the spiral artery will tear, the blood will get collect behind placenta. See here in the diagram, it has been shown that blood has collected in the green color. Okay, this. The blood gets collected behind the placenta when spiral arteries they tear. What will happen? This blood will go into the myometrium. Here, this blood will go into the myometrium. Right? Now when this blood will go into the myometrium, what will happen? See, here in the picture, blood has gone into the muscle, myometrium. So what will the patient feel? Patient will feel pain. Right? Blood will go into the myometrium. So patient will feel pain abdomen. Right? Patient will feel pain abdomen. Now the patient will feel pain abdomen. So it is painful bleeding or painless. Right? You will never do a question wrong of abruption placenta previa. Just focus here for 10 minutes. You will never do the question wrong. Okay? So, yes. So, the fetal parts, they will not, patient will feel pain. Right? There will be painful abdomen. Fetal movements will not be felt. One will not feel the fetal movements. Right? Because now there is increased pain. When we have a bruise, you see, when we have a bruise, we have a blood in the muscle, we suffer lot of pain. One question is definite from APH. Okay? So, if there is patient is having pain with the bleeding and fetal movements are not felt, and when we are examining, the fetal parts are not felt easily. Why? Because there is blood in the myometrium. Right? Fundal height increases. It means that this is the case of abruptio placenta. Okay? What is abruptio placenta? What is the triad of abruptio placenta? All of you will tell me. Fetal parts not easily palpable. Painful abdominal pain. Okay? Painful abdominal pain. painful abdominal pain, right? And the fundal height increases, right? This is a triad: painful abdomen or uterus tender to touch, right? Fundal height increase and bleeding. Fundal height increase and bleeding. And next is, yes, come on everyone, fetal distress. There is fetal distress. Okay, there is fetal distress, blood, fetal distress, because spiral arteries are tearing, so there will be fetal distress. Okay, just give me 5 minutes. So here I will give you triad of, yes, yes, now here I give you triad of abruptio placenta. Okay, what is the triad of abruptio placenta? Triad of abruptio placenta, what is there? First of all, there is bleeding. What is the triad? If these three features are present, then it means it is abruptio. Bleeding after 28 weeks. Bleeding after 28 weeks. Number 2, there is pain in abdomen. Right? Pain in the abdomen, or you can say uterus is tender to touch. Or you can say that fetal parts are not felt, because fetal parts are felt on in soft abdomen only. Fetal parts are not felt. Fetal parts not felt. Okay. Bleeding after 28 weeks. Pain in abdomen, uterus tender, fetal parts not felt. Third is fetal distress. Third is fetal distress. Right. So if you know these three things, then I'm sure that you will diagnose abruptio placenta. On abruptio placenta, there comes a clinical question, right? And due to the tender abdomen, due to the bleeding in the myometrium, there is increase in the fundal height. There is increase in the fundal height. Okay? Okay. Now let us see what will happen if there is increase in the fundal height. Okay. Now if what will happen if abruptio will occur? What will happen if abruptio will occur? Now there is blood in the blood behind the placenta. It will release the tissue thromboplastin, and this tissue thromboplastin will, once it goes into the DIC, systemic circulation of the mother, then it leads to DIC. समझ रहे हैं आप? Are you understanding my things? Right? In abruptio placenta, there is blood present behind the placenta. See, you will save a life. Save a life if you will listen it carefully. In abruptio placenta, there is blood behind the placenta. Then now that blood will release tissue thromboplastin, and when this tissue thromboplastin goes into the systemic circulation, then it starts DIC. This is a question of FMG exam. Ki what is the most common reason of DIC in the obstetrics? The answer is abruptio placenta. This is the question in the FMG exam. Why DIC occurs in abruptio placenta? Because there is release of tissue thromboplastin which goes into the mother circulation and it causes DIC. Because there is a danger that mother can go into DIC. Okay, so no conservative management in the abruptio placenta. No tocolysis, no conservative management, immediate termination. Okay, preferred mode is normal vaginal delivery. Preferred mode in abruptio placenta is normal vaginal delivery. Caesarean is done only if in the OBS indication. Okay, caesarean is only done for the OBS indication, that is mother and fetus is not stable. Preferred mode is normal delivery. So we have covered main important question. What is the mode of delivery in abruptio? Normal vaginal delivery, unless and until strict indications are there. What is the most important cause of DIC in obstetrics? The answer is abruptio. Okay, and how you will diagnose the abruptio placenta? There is triad. First triad is bleeding, genital bleeding after 28 weeks. Second point of the triad is there should be a pain in abdomen or the uterus should be tender to touch. Third point is there should be fetal distress. Right? There should be fetal distress. If these three symptoms are present, this triad is present, the diagnosis is surely abruptio placenta. Okay. Now the one-liners. One-liners also come sometime. This is, what is this picture? This is the blood has gone into the muscle of the uterus. Please listen carefully. The blood has gone into the muscle of the uterus. It's high time we have to improve our results. Okay, we have to do only short things. What is this picture? This is the cochlear uterus. Cochlear uterus. What is cochlear uterus? In myometrium, blood has gone. The another name of the cochlear uterus is, question can come on this picture, uteroplacental apoplexy. What does apoplexy means? Gussa, angerness. So uterus and placenta angerness. What does this image signifies? This is cochlear uterus. As you know that there no ultrasound, no MRI, no investigation can diagnose abruptio. It is only your clinical diagnosis, beta. No investigation, no MRI, no ultrasound, only clinical diagnosis. So clinical questions are coming on it. Okay. The classification is also on clinical symptoms and the classification name is Page classification. Right? Page classification. What is it? Complication of abruptio. Complication of abruptio is, as I already told you, that DIC occurs. DIC occurs in abruptio. Right? So we have to immediately terminate the pregnancy. So the prematurity is a set complication, right? And PPH occurs in abruptio. Why? See, this is the condition of the uterus. Do you think that uterus will contract normally? No. In the muscle, the blood has gone. Very good. In the muscle, the blood has gone. Okay, in the muscle, the blood has gone. This uterus is not going to contract normally. So, what are the two complications? Because no conservative management is done in better nothing. Dr. Isra is asking what is the management of covalent uterus? Nothing beta, it is to diagnose. We have to just be precautious that PPH will occur and manage the PPH. Okay, so it is not, and no management. So what are the complications related with abruptio? Number one, prematurity, because there is no conservative management. Okay, now lot of question comes on abruptio and uterus rupture, because uterus rupture also, especially this thing is for FMGs, because uterus rupture also presents with pain, abdomen and bleeding. So the abruptio present. How we will differentiate between abruptio and uterus rupture? Please see carefully. How we will differentiate between uterus rupture and, very important, I will give you very important symptoms. Okay, many of students, they are doing wrong in the quiz. Okay, in abruptio, you all know hypertension is the risk factor. Okay, in abruptio, hypertension is the risk factor. Okay, whereas in uterus rupture, in the uterus rupture, there is hypotension, because there is lot of bleeding. Okay, so there is hypotension. Now you remember, if hypertension is given, it is abruptio. If hypotension is given, it is uterus rupture. Then fetal parts are not felt in abruptio. In rupture, the fetus is lying in the peritoneum cavity. In uterus rupture, the fetus is lying in the peritoneum cavity. The hint which they give is that fetal parts easily palpable. Fetal parts easily palpable. Okay. Due to the rupture of the uterus, there is blood and fluid in peritoneum. No such finding here. No such finding in the abruption. What happens in uterus rupture? The uterus gets teared and the all which is inside the uterus comes in the peritoneum. Okay. So fetal parts, if they are not felt, it is abruptio. If fetal parts are felt, it means it is uterus rupture. In abruptio, mostly they give you fetal distress. In uterus rupture, mostly they give you IUD. Death occurs. Because once the fetus comes in peritoneum, intrauterine death occurs. Very important point. In uterus rupture, because the fetus is in the peritoneal cavity, so one cannot feel the fetus by doing PV. There is loss of station. What do you mean by loss of station? First, you were able to feel the fetus head. Now you are not able to feel. After rupture, you are not able to feel. Okay, that is loss of station. In the other words, we can say that fetal presenting part not felt. Fetal presenting part not felt. Once again, let us differentiate between abruptio and uterus rupture. In abruptio, the BP is high. In uterus rupture, due to peritoneal hemorrhage, the BP is falling. Fetal parts are not felt, because in abruptio, there is uterus is tender. There, the fetus has come into the peritoneum cavity. The fetal parts are easily felt. Along with fetus, the blood and fluid are also in the peritoneum cavity. Okay. Once the fetus comes in the peritoneum cavity, fetus expires. Okay. So if they tell you fetal heart rate is 100, it means that at the it is abruptio, and in uterus rupture the fetus will not be fetal presenting part will not be felt on PV. These are the important signs. Okay, now there is a term scar dehiscence. If a previous cesarean patient was going VBAC, vaginal birth after cesarean, and they have written there is suprapubic tenderness, please mind it, it is scar dehiscence. The previous uterus scar is going to rupture, not uterus tender. They have very smartly given in your questions suprapubic tenderness. All these topics are very favorite of FMG examiners. What is suprapubic tenderness? This time there is no generalized uterine tenderness. There is suprapubic tenderness. Suprapubic tenderness means this is uterus scar, previous cesarean scar. The tenderness is limited only up till here in the suprapubic area. If the suprapubic tenderness word is used, it means that it is scar dehiscence. In VBAC, that is why mesoprost and prostaglandins, they are contraindicated. They are contraindicated because mesoprost lead to scar rupture. Okay, mesoprost lead to scar rupture. Now let us discuss placenta previa. What is placenta previa? The placenta is lying in the lower segment. See, this is the classification of placenta previa. Last time in the FMG we got a question from placenta previa classification. It is quite expected this time also. Okay, what is placenta previa? Listen carefully. I am telling you much expected questions from APH. Okay, if the placenta is more than 2 centimeter away from the os, away from the os 2 centimeter, if the placenta is at a distance of 2 centimeter from the os, it is low lying placenta. Okay, if that placenta is covering just the margin of the os, see, it is coming just at the margin of the os, but it is not covering the os. It is marginal placenta previa, less than 2 centimeter, but not covering the os. It is marginal. Okay, and if it is partially covering the placenta is partially covering the os, it is partial. And if it is totally covering the os, it is complete. Very, very important images. Okay, this is low lying. Low lying is more than 2 centimeter away from the os. Away from the os. And what is marginal? Not coming on the os, but touching the margin of the os. Okay, what is partial? Partial means covering the os partially, and complete means completely covering. Okay, this was the image in the last FMG exam. The expected image is this, marginal in these exams. Okay, expected image is marginal. The one which is not covering the os slightly also, and it is less than 2 centimeter. Because if it will be more than 2 centimeter, then it will be low lying placenta. Okay. Okay, placenta previa. Okay, much expected question. You have to differentiate. They give you the clinical scenario. Patient has came with bleeding after 28 weeks. It's diagnosed that whether it is placenta previa or abruptio. Abruptio cannot be diagnosed on ultrasound. Abruptio cannot be diagnosed on ultrasound. Abruptio cannot be diagnosed on ultrasound. Placenta previa is diagnosed on ultrasound. But you should know the clinical features. Okay. Abruptio presents with fresh red colored bleeding. Okay, fresh red colored bleeding. The bleeding is not associated with pain. Bleeding is not associated with any cause. Like preeclampsia, the uterus is relaxed and uterus is non-tender, all opposite to abruptio. So when you are diagnosing any patient as placenta previa, if you don't have ultrasound, then you have to see these features which are opposite to abruptio. Fundal height is also equal to period of gestation. What is warning hemorrhage? Because inside the uterus there is fetus. Fetus kicks. Fetus kicks and placenta is lying in the lower segment. So there is some bleeding. But soon the nature recovers that bleeding. So that is known as warning hemorrhage. What is warning hemorrhage? Small bleedings. Small bleeding which stops spontaneously, because it is due to the kicking of the fetus, right? Because we know that these bleedings, placenta previa is associated with warning hemorrhage, so we have to not take this bleeding seriously. We have to wait to see that the bleeding is stopping or not. We have to wait. So we have to give the conservative management. Only if the conservative management fails, then we have to do the cesarean. In placenta previa, normal vaginal delivery is contraindicated. Okay? In placenta previa, the normal vaginal delivery is contraindicated. Okay? In placenta previa, normal vaginal delivery is not done. Right? In placenta previa, we do cesarean. So we are not going to do cesarean if it is warning hemorrhage. For every hemorrhage, we have to stop and see that this hemorrhage is stopping or not. Okay? So the regimen which we give is this conservative management. Is what is its name? One liner. Again one liner. Many of you are doing wrong in the quiz. The name of the regimen is McCafe-Johnson regimen. Usually come with the name of McCafe. Okay? Usually came with the name of McCafe. Okay, McCafe. What is the McCafe-Johnson regime? We give bed rest to the patient and betamethasone. We give bed rest and betamethasone. Okay, we give bed rest and betamethasone. Right? We will not give the conservative management or McCafe regimen if the period of gestation is more than 37 weeks, if there is fetal and maternal distress, if bleeding keeps on continuing, we will not give McCafe. It means it is not a warning hemorrhage. It is a sure shot or distress problem. Okay? And if there is intrauterine death or fetal anomaly, then again we are not going to do conservative management, because we were doing conservative management only to prolong the period of gestation so that fetus can get mature, right? So we are not going to do conservative management if period of gestation is more than 37 weeks, if there is fetal or maternal distress, if there is intrauterine death or fetal anomalies are present. Okay? So this is the management they ask. In placenta previa, either they ask the questions on image or they ask the what is the when you will do conservative management, when you will do cesarean. Is it clear? Is it clear? Any queries till now? Please be free to ask. Now, if there is history of if the patient has placenta previa, and there is history of previous cesarean. Okay, if the patient had history of placenta, patient has placenta previa, and there is history of previous cesarean or any previous uterine scar, then you must rule out placenta accreta. Thank you, Dr. Isra. You should must rule out placenta accreta. What is placenta accreta? What is placenta accreta? Placenta accreta means that there is absence of nita butch layer, and the villi are attaching to myometrium, right? So if there is placenta previa and previous history of cesarean, you should rule out placenta accreta. Okay, placenta accreta should be ruled out. Okay, so it is very important. It is known as placenta accreta spectrum. If the patient is having placenta previa on ultrasound and previous history of cesarean, placenta accreta should be ruled out. What is the investigation of choice of placenta accreta? Ultrasound or MRI? Best is MRI. Most commonly done is ultrasound, but if ultrasound is not helping, then MRI. What is the treatment of placenta accreta? Treatment of placenta accreta is hysterectomy. Okay, what is treatment of placenta accreta? Treatment of placenta accreta is hysterectomy. Post cesarean hysterectomy. Along with the cesarean, once you take out the baby, you have to do hysterectomy. Okay, what is the third most important cause of abruptio placenta? The third most important cause is vasa previa. The third most important cause of placenta previa is vasa previa. Okay, the vessels. What is vasa previa? Placenta previa means placenta in the lower on the os. Vasa previa means blood vessels on the internal os, right? Which is the placenta associated with the vasa previa? The placenta which is associated is filamentous. What is filamentous placenta? Filamentous placenta means that the vessels, usually vessels, they separate once the umbilical cord insert on the placenta. But in the filamentous placenta, the vessels, they separate before the cord separates. So these vessels, they now lie on the internal os. These vessels, now they lie on the internal os. This is known as the filamentous placenta or vasa previa, right? What is filamentous placenta? Filamentous placenta means vessels separate before the cord inserts, and then now the vessels, they insert on the membrane. Filamentous placenta is the another name of membranous placenta. Okay, now when these vessels, they are separated, now when these vessels come on internal os, this is known as vasa previa. What is the management of vasa previa? The management is cesarean. Okay, now let us study the diabetes mellitus. Okay, diabetes mellitus. The pre-gestational, what is pre-gestational diabetes? If the diabetes, one short question on diabetes mellitus. Today's last topic is diabetes mellitus in pregnancy. Okay, one short question on diabetes mellitus which they will ask you is that what is congenital anomalies occurs in which diabetes? In pre-gestational or gestational? What is gestational diabetes? The diabetes which is due to pregnancy. And what is pre-gestation? Pre-gestational diabetes means the diabetes which was already present in the patient before pregnancy, right? So congenital anomalies occur in which diabetes? Write down in the chat box the answer. The congenital anomalies occurs in which pregnancy? Congenital anomalies in the fetus occur in which diabetes? Sure, short question of diabetes mellitus. Congenital anomalies occur in pre-gestational or gestational diabetes. Yes. Why it occurs in pre-gestational? Dr. Isra, you are right. Why it occurs in pre-gestational diabetes mellitus? Because in pre-gestational diabetes mellitus, there is glucose derangements in the organogenesis period, right? Gestational diabetes mellitus occurs in after 24 to 28 weeks. When does gestational diabetes mellitus occurs? Sure, short question बच्चे, आना ही आना है. After 24 to 28 weeks, gestational diabetes mellitus occur, and by that time the organogenesis has completed. By that time, organogenesis has completed. Okay, so no congenital anomaly in gestational diabetes mellitus. Only in pre-gestational diabetes mellitus there is congenital anomalies. Okay, what are the complications which occurs in both pre-gestational and gestational? Macrosomia and polyhydramnios. Which is the most specific congenital anomaly of pre-gestational diabetes mellitus? Sacral agenesis. This is sacral agenesis. Sacral, what is the another name of sacral agenesis? Caudal regression. If a fetus has this syndrome, it means that his mother was having pre-gestational diabetes mellitus. Okay, it means that the fetus mother had it is much specific. This is caudal regression syndrome or sacral agenesis. Okay, caudal regression syndrome. Okay, please be energetic to write the answer. Which is the most specific anomaly? Which is the most specific anomaly, beta? Yes, write down. Sacral agenesis or caudal regression syndrome. One and the same thing. Okay. And which is the most common anomaly? Which is the most common anomaly? It is most specific and it is most rare. Which is the most common anomaly in the patient of pre-gestational diabetic mellitus fetus? Please write down in the chat box. Cardiac anomalies occur and it is the VSD. Cardiac anomalies occur and it is the VSD. Okay. Cardiac system gets affected most commonly and it is the VSD. How to diagnose? Second question. First question on diabetes mellitus was anomalies occurs in which and which anomalies occur. The second question, how to diagnose gestational diabetes mellitus. What is the criteria? So IADPSG has given us 75 gram glucose tolerance test. What is the best test? 75 gram glucose tolerance test. What is the value? Anyone? 75 gram glucose tolerance test is done, beta. Okay. Very good. The fasting value of 75 gram glucose test, 92. Okay, to diagnose, what is the cutoff value? 92. 90 का डबल कर दो, 180, 1 hour की वैल्यू. Okay, double the 90, 180. Then after 2 hours there will be small reduction. What will be that? It is 153. It is 153. Okay, so the cutoff value of fasting is 92. Then 1 hour value is 180. and 2R value is 153. Is it okay? Now, what is the cutoff value to say pre-gestational diabetes mellitus? The fasting value is 126 and 2R value is 200. The cutoff value to diagnose pre-gestational diabetes mellitus is 92 is normal. Yes, no, 92 or more than 92. Diagnose the gestational diabetes mellitus. For to diagnose pre-gestational diabetes mellitus, the cutoff value is 126 fasting and 208 for the pre-gestational diabetes mellitus. Question was asked. What was the question? What is the 70? What is the test we do as per IAD-PSG? 75 gram glucose tolerance test after 2 hour. 2 hour. So we have got three values: fasting 1 hour, 2 hour, and it is done at 24 to 28 weeks. And it is done at 24 to 28 weeks. Okay. What is the test done to diagnose the GDM or pre-gestational diabetes mellitus? 75 gram 2 hour glucose tolerance test. Right. Now, Indian Diabetes Society is DIPSI. Indian Diabetes Society is DIPSIs. DIPSI says no need for the patient to come fasting. Okay. So, DIPSI said just give 75 gram glucose and calculate the value after 2 hours. If it is more than 140, it is gestational diabetes mellitus. If it is more than 200, it is pre-gestational diabetes mellitus. It is pre-gestational diabetes mellitus. Okay. No three values in the case of DIPSI. Only one value for gestational diabetes mellitus, that is 140, and only one value same. The value for pre-gestational diabetes mellitus is same in IAD-PSG and other. Okay. Is it okay? Once it was asked in FMG exam that yes, then if there are symptoms of hyperglycemia, then you can do it at any time. Okay. If there are symptoms, Dr. Isra, if there are symptoms of hyperglycemia, then you can do it anytime. But if there are no symptoms, then you have to do it at 24 to 28 weeks. Okay. What does ACOG says? ACOG says do 50 gram glucose tolerance screening with 50 gram, and after 1 hour see the value. It should be, if it is more than 140, then patient is a candidate of gestational diabetes mellitus. Okay. ACOG says the test to be, ACOG says the test to be, yes, 50 gram glucose tolerance test. Okay. So once it was asked in FMG, what is the 1 hour value of 50 gram glucose tolerance test? That is why I have put here in the slide that it is 140. Once again, what is the IAD-PSG values? Fasting is 92. 1 hour value is 180. Double of 90. 2 hour value is 153. Right? And what is DIPSI criteria? DIPSI says 140 for gestational diabetes mellitus and 200 for pre-gestational diabetes mellitus. Okay. And what is the ACOG says? ACOG says it, yes, 50 ग्राम टेस्ट के साथ जो है हमने 1 आवर बाद शुगर देखनी है 140. Is it easy or are written on one side only? What is the management of diabetes mellitus in pregnancy? Okay. The management of diabetes mellitus is of course insulin. It is insulin, no doubt. but we have to, because the patient of the fetus of diabetes mellitus can expire, so we have to do bi-weekly NST after 32 weeks. After 32 weeks we have to do bi-weekly NST. Okay, if the diabetes is well controlled, then we have to terminate it at 39 weeks. Okay, if the diabetes is well controlled, then we have to terminate it at 39 plus. If the diabetes is poorly controlled, whether on insulin or diet, then we have to terminate it at 36 to 38 weeks, 6 days. Easy? Is it easy? If the diabetes is well controlled on diet or on insulin, whatever, okay, then you have to terminate it from 39 to 40. In between 39 to 40 weeks. If it is not well controlled, sugar levels are going up and down, it means it is a risk of IUD, then you have to terminate it at 36 to 38 weeks, 6 days. Okay. Okay. Now, what are the problems which we have in neonate? Now, if you will listen it carefully, you will remember all hypo occurs. You know that when the fetus is inside the uterus, fetus is suffering from hyperglycemia. But once the fetus come outside, then the fetus has all hypo. Okay. So keep on asking, they keep on asking these things. Okay. The fetus has hypoglycemia. Once the fetus is delivered, fetus has hypoglycemia, hypocalcemia, hyponatremia, hypomagnesemia, hypokalemia. Okay, because it is very easy, they keep on asking this thing. Okay, they keep on asking this thing. The fetus has hypoglycemia, hypocalcemia, hyponatremia, hypomagnesemia, hypokalemia. In the options, they give you hypercalcemia or hyperkalemia. Please remember, it is not hyperglycemia, not hypercalcemia, all hypo. Once the fetus has come out, now fetus will not be, is under the influence of mother glucose. Now fetus is detached from the mother. So now the fetus will have all hypo conditions. That's all in the diabetes mellitus in pregnancy. Okay. So once again we will be doing the images. What does this image says? What does this image is? This image is sacral agenesis, and this problem occurs only in pre-gestational diabetes mellitus. It does not occur in gestational diabetes mellitus. Okay. These placentas. Okay. What is this type of placenta? Let us ask you, what is this type of placenta? Write down in the chat box, what is the type of placenta? This placenta का क्या type है? Yes, this is marginalis. This is type 1, this is type 2, this is type 3, and this is type 4. So this is type 2. Okay, this is type 2. Okay. What is this image shows? What does this image shows? Cochlear uterus. This is the image of cochlear uterus and it is found in abruptio placenta. Now I will be asking you all the questions I have done. Here I will be asking you some 10 questions and they will surely come in your exam. Management of severe preeclampsia. Its management is antihypertension plus mexsulfate plus termination at 34 weeks. Okay. Management of eclampsia. Airway management. Airway is to be maintained. Along with it, you have to give mexsulfate and antihypertension, and you have to antihypertension and you have to terminate immediately. Right? In the severe preeclampsia, what is the management? The management is mexsulfate plus antihypertensive plus termination at 34. Sure, short question. I will give you 10 questions and sure the question is coming from it. Number 3, the signs of impending eclampsia. The signs of impending eclampsia. It is cerebral hypoxia signs. That is headache, visual symptoms and liver toxicity signs. What were they? Epigastric pain, nausea, vomiting. The another question which is expected on from preeclampsia is on mexsulfate. Right? What is the therapeutic range of mexsulfate? 4 to 8. What is the hypotonia? When does deep tendon reflexes goes? 8 to 12. 4 to 8 is the therapeutic range. Right? 8 to 12 is the deep tendon reflexes, or you can say knee reflexes goes. Right? And after 12, the 12 to 16 are the respiratory problems. Respiratory depression occurs. Okay. Other than this, you have also to see the urine output, because mexsulfate is mainly excreted to urine, more than 30 ml per hour. Right? This is it. Yes, you are right. Dr. Hassan, you are right. So urine output is more than 30 ml plus 30 ml per hour. Okay. Next it is after mexsulfate you have to see that urine output is more than 30 ml. What is the maintenance dose of mexsulfate? What is the maintenance dose of mexsulfate? What is the maintenance dose of mexsulfate? Please write down. 5 mg IM 4 hourly, 24 hours after delivery, 24 hours after delivery, or after last seizure, whichever is late, after last seizure. Okay, after last season. Right? This is the maintenance dose. 5 milligram IM 4 hourly. Okay? After the 24 hours after delivery, whichever is later. And what is the effect of mexsulfate on fetus? The effect of mac sulfate on the fetus is same that of the mother. It causes hypotonia in the fetus and it causes respiratory depression. Same that on the mother. Okay, same that on the mother. After that, they ask you that does mac sulfate lowers BP? Write down in the chat box yes or no. Mac sulfate lowers BP or not? Yes or no? No, no effect on BP. Mac sulfate has no effect on BP. Okay, mac sulfate is only neuroprotective and it is neuroprotective for fetus also. Okay, it is also neuroprotective for fetus. After this, in the APH, they ask you what is the triad of APH. What is the APH triad? Write down in the chat box what is the APH triad. Bleeding after 28 weeks, fetal distress, and pain abdomen. Pain abdomen and uterus tender. Okay. Okay, so this is the APH triad. And then there is no conservative management in the no conservative management. No conservative management. No conservative management in abruptio. Immediate delivery. Right? As the patient can go into DIC. As the patient can go into DIC, immediate delivery. Okay, most common cause of DIC in obstetrics is yes, very good. Very good, Dr. Isra. Right? In the placenta previa, you will be asked when to do conservative management and when to do cesarean. So, conservative management is only done in the placenta previa. They will ask you when is the conservative management done. Okay, in the placenta previa, the conservative management is done if the period of gestation is less than 37 weeks and there is no fetal and maternal distress. What is the regime name which we give for placenta previa? McCafe regimen. McCafe regimen. McCafe regimen. Conservative regimen name is McCafe regimen. Okay. In the diabetes, the short question which they can ask you is that congenital anomalies in the fetus occur in which fetus? In the gestational diabetes mellitus or pre-gestational diabetes mellitus? Congenital anomalies in diabetes mellitus fetus occurs in which? Write down in the chat box. In gestational diabetes mellitus or pre-gestational diabetes mellitus? Answer is pre-gestational diabetes mellitus, because gestational diabetes mellitus occur after 28 weeks. Okay, gestational diabetes mellitus occur after 24 to 28 weeks. Till then, organogenesis is completed. Then they can ask you the diagnosis criteria. Right? They can ask you the diagnosis criteria. The IADPSG criteria. IADPSG criteria or American Diabetes Association. They say that at 24 to 28 weeks, we have to undergo 75 gram glucose tolerance test in a pregnant patient. Okay, 75 gram glucose. No, no, Dr. Isra, we cannot wait. DIC is an emergency. We cannot wait for 48 hours. Okay, Dr. Isra, we cannot wait in abruption. That is why prematurity is the complication. Is it clear to you, Dr. Isra? 24 to 28 weeks, age 75. What are the values? Write down in the chat box. What are the values at 24 to 28 weeks? Write down. What are the values of 75 gram glucose 2-hour test? 92, double it. After 1 hour, 180. After it, 153. Okay, 92, 180, 153. Okay, what are the DIPSI? Indian Society, Indian Diabetes Society says no need to ask the woman to come fasting. Whatever the woman has eaten, do the test. Give 75 gram glucose test and do the test. It is 140 post 2 hour. As per DIPSI, it is, yes, 140 and 200 for pre-gestational diabetes mellitus. What is the most common congenital anomaly? Most common congenital anomaly in pre-gestational diabetes mellitus fetus. Yes, what is the most common congenital anomaly in pre-gestational diabetes mellitus fetus? It is cardiac defect. VSD. Okay, it is cardiac defect. Beta, Dr. Isra, I am asking in most common. Okay, sacral agenesis is most specific. Okay, sacral agenesis is most specific. Most specific is caudal regression syndrome or sacral agenesis. Okay, now they ask you what is the management. Of course, insulin is the drug of choice. Then they ask you when to terminate. If the sugars are controlled, whether they are controlled on a diet or whether they are controlled on insulin. If the controlled sugars are there, right, then your treatment is, you will terminate the pregnancy at 39 weeks to 40 weeks. Is it clear? Is it clear? And if the sugars are uncontrolled, then you will terminate the pregnancy at 36 weeks to, beta, it is, Dr. Isra, it is 36 weeks. If the sugars are uncontrolled, then you will terminate it at 36 weeks to 38 weeks, 6 days. Okay, clear your things, Dr. Isra. It is at 36 weeks to 38 weeks, 6 days. And in the fetus of, in the newborn of 36 to 38 weeks, 6 days. Okay, and if it is a newborn of diabetes mother, what all complications we will have? All hypo. All hypo. That is, we will have hypoglycemia, hypocalcemia, hypomagnesemia, and all hypo. Sugars and all iron, hypophosphatemia, everything hypo. Okay. What all are the drugs contraindicated in pregnancy? Antihypertensive drug. What is the drug of choice? What is the antihypertensive drug of choice? Write down in the chat box. It is labetalol. Right? What all are contraindicated? The contraindicated antihypertensives are, yes, angiotensin receptor blockers, angiotensin convertase enzyme inhibitors, okay, then beta blockers, diuretics, and diazoxide. That's all for today. I hope you have improved your concept. Please write in the chat box if you have any queries. Tomorrow we will be completing the twins antenatal surveillance Rh negative, and we will be doing labor. Okay. So by that our obstetrics will be completed. Yes, Dr. Isra, you are right. Please write down in the chat box if you have any query. Tomorrow we will be completing this second and third trimester problem, and we will be starting with labor. Okay, thank you. So here we will be closing the session.